Thank you, Vijayashree. And indeed, it's a kind of pleasure and an honor to collaborate with KNCV, which is an organization with long-standing partnership with WHO in organizing this webinar. So I welcome you all to this webinar, which is about sharing experiences and practical lessons in introduction, scale up, and innovation for the use of stool test for diagnosis of TB. I already see more than 100 participants here, which includes national TB programs, TB experts, laboratory experts, communities, donors like the Global Fund, of course, WHO, and several other agencies participating. So I think this is going to be an exciting time. I won't take long, but just to lay to start off with a stage for these discussions, why Southeast Asia Regional Office and the region itself is important for such discussions. You know, we are the highest TB burden region amongst all WHO regions. We have nearly half the TB incidence, and in fact, more than half the TB deaths in this region. About 5 million TB cases are kind of estimated to have emerged in the region during 2023. Of course, we have been doing well. We reached out to 78% of those patients, but I think that's not all. And specifically, when we talk of children, when we talk of younger populations, we know we haven't done enough so far, missing a huge proportion. So I think this particular guidance, which came from WHO on stool-based testing, it actually aims to address an important hurdle in what specimen to use and how to diagnose TB in children. And again, thanks to KNCV, who are taking this agenda forward by information dissemination, by capacity building, and supporting countries adopt and roll out this methodology for diagnosis of TB. So back to you, Vijayashree. We hope to have very lively discussions. I still see people coming in, but I think in the interest of time, let's start off with the main agenda. Thank you,
Yeah,
and over to you.
yeah. Thanks, Vineet. Now I open the floor for the speakers. Now I would like to call upon the first speaker, Dr. Sabine, who is a medical officer at the Global TB Program at WHO. Her work focuses on policy development on the management of TB in children and adolescents and other at-risk population. And she has been involved in providing technical support to countries in this regard. Over to you, Sabine.
Thank you very much for that kind introduction. So
Yeah.
thanks very much for the kind invitation. I'm really presenting on behalf of the team within WHO Global TB Program that deals with children and adolescents. And I can see my colleague Annemieke Brands is also online. So she will also be able to help with answering any questions. So just to start with some epidemiology, out of the 10.8 million people who were estimated to have developed TB in 2023, 1.25 million were children and young adolescents below, under the age of 15. And the estimates are that almost 200,000 of these youngsters died in 2023. So that is, the burden is about 12% of all people with TB, whereas the deaths are about 15%. So you can see there is a disproportionate mortality in children. And also, if you look at in more detail at the data, you can see that the majority of deaths are in children who are young, children under 5, and also the vast majority of deaths occurred in children who did not access TB treatment. So that really means that we need to do more to find children affected by TB. So if we go into a little bit more detail in terms of how many children and young adolescents are we actually finding amongst those who are estimated to have TB? This graph gives you an overview for the different age groups. And you can see in the bars, the yellow part is those who are the proportion that are detected, and that those data are for 2023. So 48% of children under 5 years old are detected, but we have a gap of about 52%. And overall, in the age group under 15%, the gap is about 45%. So you can see the gap is highest in the youngest children. And of course, that has to do with the difficulties of diagnosing TB, especially in young children. And there on the right, you can see a list of reasons for the treatment coverage gap. So it has to do with the fact that children usually present with paucibacillary TB. So you don't have, it's not easy to detect TB because there are so few bacilli. So currently we do not have a point of care test that is sensitive enough to pick up TB in children. And then of course there's challenges with collection of suitable respiratory samples. There's also overlap of symptoms with other common childhood diseases. And generally, we see there's limited capacity to diagnose children with TB in terms of sample collection, access to testing, and access to chest X-ray, and also confidence in making a clinical diagnosis. So the next slide shows a few more gaps. Another gap is around the provision of TB preventive treatment. And you can see that in 2023, amongst the contacts aged under 5, only 42% received TPT. So we also have a big gap in terms of providing preventive treatment to children who are in contact with people with TB. Another gap, and that's the biggest one actually that we have, is around MDR and rifampicin-resistant treatment initiation or case finding as well. And you can see that we don't have official WHO estimates for the number of children who develop MDR and RRTB every year, but we have some modeling data that show that around 30,000 per year develop MDR and RRTB. And based on the current data, we only initiating about 14% of these children on second-line treatment. So this is actually the biggest gap. So that's why it's important to really know if children with TB have any drug resistance to ensure that they are treated, that are started on the appropriate treatment. Coming to WHO guidance, you can see here on this slide the guidance covers the full cascade of care, and you can see the link to the guidelines as well as the operational handbook and the WHO knowledge sharing platform. So in those documents, we cover the entire cascade of care from TB screening, and I won't go into all the details now, TB prevention, diagnostic approaches, of course, most relevant for this webinar in terms of using rapid diagnostic tests and the specimens that can be used. And also we have details on integrated treatment decision algorithms with evidence-based examples in the operational handbook. In addition, obviously, the guidance covers treatment, shorter treatment for non-severe TB, alternative regimens for TB meningitis, and then also treatment for drug-resistant TB. So just to also highlight the roadmap towards ending TB in children and adolescents, the third edition was published in 2023, and it really aims to define actions to be prioritized and implemented to reduce TB-related morbidity and mortality. It's aligned with the UN high-level meeting targets, the updated targets in 2023, and it has 10 key actions that cover a wide range of issues, including child-friendly diagnostic approaches, obviously. So it's available in French and Spanish, and you can access it through this QR code or through the link at the bottom. In terms of guidance, so let me try and move to the next one. In terms of guidance on diagnostic approaches, WHO has recommendations on the use of low complexity NAD tests. So those are the tests like expert MTB-RIF and ultra on a variety of specimens, including stool. And then recently we published a rapid communication, which is really a sort of a precursor to upcoming changes to the guidelines. And in this case, it's guidelines on rapid diagnostics, which has a recommendation on parallel testing, meaning that we need to use a respiratory specimen and a stool specimen in children, and combined with an LF-LAM for children who are HIV positive. So I've got the link there to the rapid communication, and the full guidelines with an operational handbook are expected to come out later this year. Then we have an interim recommendation on treatment decision algorithms with evidence-based example algorithms in the operational handbook. And I'll go a little bit in a little bit more detail on that as well. So going into the current recommendations on the use of molecular WHO recommended diagnostics, we have recommendations on expert ultra and expert MTB-RIF. So both NAD tests should be used as the initial diagnostic test for TB and rifampicin-resistant detection in all pediatric specimens. So that includes sputum that can be induced or expectorated, gastric aspirate, nasopharyngeal aspirate, and stool. And you can see that the gastric aspirate and stool recommendation for ultra was added in 2022. And these recommendations are both strong, but based on varying certainty of evidence. And then in the operational handbook, we have details on the kind of specimens that can be used on the different tests. And of course, you can see stool there, and I think Petra will also cover this table from the handbook. And then there's a very useful practical manual on processing stool samples for the diagnosis of childhood TB that's also being published in collaboration with the Global Laboratory Initiative. In terms of diagnostic accuracy of low complexity automated NADs in pediatric specimens, you can see this table here, which is from the 2022 guidelines. And of course, there's additional data that has been reviewed for the upcoming update, but these are the accuracy data that we have currently. You can see that for MTB-RIF, stool has a sensitivity of about 61%, then a specificity of 98%. And for HIV positive, that's a bit higher, 70% sensitivity. And then for expert ultra, the sensitivity is around 53%, with still a very high specificity. And then for the upcoming guidelines, further data were included, and the overall pooled sensitivity of stool testing in low complexity automated NADs is around 65%. So it's quite good and quite comparable to other respiratory samples. In terms of the treatment decision algorithms, this is the top part of both algorithms, which really look at danger signs first and then a risk assessment. Children with a high risk of rapid progression to severe forms of TB should be going through the algorithm immediately, and others should first be treated for the most likely non-TB conditions. And then, of course, the collection of specimens, including stool specimens for rapid testing is recommended there as well, and including urine LF-LAM for children with HIV. And then the bottom part of the algorithms really has a scoring system based on signs and symptoms and based on chest X-ray features. And what is important to note is that the sensitivity for this scoring part, it's just the scoring part, not the additional steps, is about 85%. And then the specificity for algorithm A, which is the one with chest X-ray, 37%, and algorithm B, which is the one without chest X-ray, 30%. And additional steps were added to improve performance. And it's also important to note that these algorithms have only been validated internally, and external validation is ongoing with quite a number of studies happening at the moment. So just to go in a little bit more detail on the updates on concurrent TB testing with low complexity automated NATs. So we have an upcoming recommendation that has already been flagged in the rapid communication for children with signs and symptoms or a positive screening test to do a test on respiratory samples and a stool sample. This is a strong recommendation based on low certainty evidence. It is strong because there are large desirable effects, because it's so important to rapidly and accurately diagnose TB in children who are a highly vulnerable population. And concurrent testing should be prioritized over the use of a single molecular test. However, the evidence does support the use of a single test on sputum, gastric aspirate, stool, and MPA as initial diagnostic tests as well. And then for children with HIV, it is concurrent testing with 3 tests. So it's a respiratory sample and a stool sample and LF-LAM on urine. Now that's a conditional recommendation, also with low certainty evidence. So as I said before, the full guidelines and the full operational handbook will be published later this year, probably I think by March or April. And just to reflect a little bit on implementation considerations around concurrent testing. Of course, it will be more costly to take 2 specimens instead of 1, but the evidence did show it was cost effective, as you will diagnose more children because the sensitivity is higher when you use two tests. Obviously, taking a respiratory specimen will remain challenging, especially in young children, and it requires special skills, equipment, consumables that may not always be available at the lower levels of the healthcare system. And we need to take into account that WHO also recommends decentralization and integration to lower levels of care and into child health and primary care programs. That's why it will really depend on the systems that are in place or that are being planned to be put in place at various levels of care. Of course, capacity building will be very important. Capacity building, mentoring, equipment and supplies, and it will also need to feed into the hub and spoke systems that are in place to ensure a short-term turnaround time. Of course, stool testing will remain a critical non-invasive approach to bacteriological testing, and in practice, having at least 1, but trying to get 2 different samples will be important to increase case finding, especially also of drug-resistant TB. However, clinical capacity to make a clinical diagnosis and expanding access to chest X-ray will also be important, especially for drug-resistant TB, as we've seen the largest gap is there. And there hasn't really been much progress in the last few years. There's been much better treatment, but if we don't find the children, they cannot benefit from it. And then obviously there's a lot of studies going on to externally validate the treatment decision algorithms. And these have triage and risk assessment steps. And obviously bacteriological testing is an important step in the algorithm. And then concurrent testing of a respiratory and a stool sample with LF-LAM as indicated can easily be integrated in those algorithms. But ultimately, the implementation will really depend on what's most feasible and acceptable in the local context. And the approach may need to be tailored to the level of the healthcare system and the capacity in place. So countries need to dedicate attention and budget to this in the national strategic planning and funding applications as well. And operational research, such as presented in this webinar, will be very important to understand the requirements and the performance under programmatic conditions. So we have e-courses on TB in children and adolescents for 2 different target audiences. Those are in the process of being transferred to the WHO Academy. So these links that you see on these slides are not currently working, and we can inform everyone once these courses are back up and running. I just wanted to end here and thank our colleagues at the WHO Global TB Program, especially our director and unit head, and also colleagues directly working on ending TB in children and adolescents, Kerry Viney, Annemiek Brands, and Tiziana Massini. Thank you so much for your attention.
Thank you, Sabine. Thank you for emphasizing on the WHO's guidance on integrating rapid molecular diagnostic tests, the concurrent testing with stool and respiratory specimens. I'm sure our audience will have questions. Now we will move to the next presenter, Petra de Haas. She's a senior technical laboratory advisor and a scientist from KNCV. She invented the Simple One Step Stool method for diagnosing TB in children, and she has been providing technical assistance to some of the countries to end TB. She advises on the laboratory network through NTPs and other TB partners. Dear Petra, over to you.
Okay, great. So I will speak about the childhood TB in the area of stool-based testing, and I will focus mainly on the on the SOS Stool method, also called the Simple One Step Stool method, that is developed, invented by KNCV and together with many countries that have helped us coming to where we are now. So I first would like to summarize the guidance that Sabine already mentioned. So there are indeed 3 documents that are really important for the implementation of stool-based testing. The first one, the model 3 on diagnosis, you can see already since 2020, stool-based testing was recommended by using by expert MTB-RIF, and since 2022 we also have the stool recommended by expert ultra. And the model 5 that was clearly discussed by Sabine. Finally, in 2022, we were also having a recommendation on stool-based testing, and we also had the clinical algorithms and the stool processing methods, as I said, were recommended. And after this recommendation, we developed the practical handbook on the introduction of stool-based testing, which you see also here as the last document, that also has a lot of practical consideration and indicators. I'm not sure if any of you have already seen this document, but it's quite a rich document when you start implementing the stool-based testing. So just to come to the simple one-step stool processing method. So the simple one-step processing method is one of the 2 methods that is recommended by WHO. It has shown similar sensitivity and specificity compared to the more complex methods. So there were head-to-head comparison studies done that has shown the similar sensitivity and specificity. So there are no additional supplies required than for sputum expert testing. So it has the same kind of tools and materials that is needed. So that's also why it is easy to implement at a low cost at any expert site. Lab personnel finds it very easy to perform the test. We have done some questionnaires among the lab personnel, and they clearly came to this conclusion. It's a minimal training that is required, and the method is robust and showed a relatively low error and invalid results. And you can see the sources of the publications that have came out around these topics on the slide. So how simple is it? So just to make it clear, you take a little bit of stool, an aliquot of stool, which is between the 0.3 and 0.8 gram, and you bring that into this little bottle that comes with the expert cartridge. Then you have to shake this, and so you shake it first, and then you let it stand for 10 minutes for incubation. You shake it again, and you let it stand another time for sedimentation. So after the 2 times 10 minutes, you transfer the upper layer of your supernatant into the cartridge, and it is ready for testing. So as I said, there's no need for any additional equipment or supplies in comparison to sputum expert testing. So just to give you a little bit of background information. So we have done a lot of experience to find out about the robustness of the stool SOS stool method, but also on the stool storage condition, because there was a lot of questions around how to keep the stool during transport or when it is taken from the patient. And so we have done a lot of experience. This was done together with the APHI in Ethiopia. We had in total 47 TB patients that were enrolled, which among there were 20% were children. 132 stools were collected, and there were more than 2,900 stool aliquots tested. So we did a lot of testing to find out a lot of things around sample strategy, but also on stool storage condition, as I said, and also what would be the best amount for stool to be taken. And just to give a little bit of an example, this is the results that came out on the stool storage, and our conclusion from this experiment, where we have put the samples into the fridge, into room temperature, as well as an incubator of 36 degrees for more than 10 days. We could conclude from the results that stool can be kept at a high temperature, but there is a higher risk of increasing errors and invalids. So the cold chain would always be beneficial. We looked into the robustness and the stool storage condition of the SOS stool method, and it showed clearly that stool can be kept at a higher temperature. Of course, like also for sputum, it also benefits from a cold chain if that possibility is there. Just to give also a kind of idea of what has been the uptake. So as I said, since 2020, stool was officially recommended. And up to now, many countries started to introduce the SOS stool method, or the stool-based testing, let me say it, and keep it in general. In this map, you will see the countries that are already, to our knowledge, implementing the stool test. And there are 3 categories. So you see that some countries in green that already have implemented it on nationwide implementation. There are some countries that are doing the pilot, are in the pilot phase, which are the yellow countries, and there are some countries that are already in planning. And of course, this is what I say to our knowledge, and we every time hear more from other countries that they also have started already. So please let us know if you already started and your country is not colored here yet. And so we did. Let me click here. So we had the opportunity to have a workshop on stool-based testing at the Union Conference in 2023, and there we had a number of countries that were presenting their data, the first early data on stool-based testing, and here you can see the results. This has been brought together in a publication, and the publication is accepted by AID and will soon be available for everyone to see. But you can see that there were more than 60,000 stools already tested, and the positivity rate was around 4.9%. We also have done another Union Conference, the last year conference. I think many of you may have been there, and we had another opportunity for a stool a workshop. And here you can see the countries that have presented, and most of them are presenting also at this webinar. Just to also say more on the stool-based testing to detect TB, why it is so successful, why we think it's so successful, and I give you some sources here that would be interesting to read. But in conclusion, we can say the SOS method is an easy to perform and can be done at every expert site and beyond. So from our study, the occurrence study that we did in Ethiopia, where we tested the expert sputum against the stool, we came to a sensitivity of 79% and with a high specificity against the expert respiratory sample. Stool can be used as a rule-in test, as the specificity is very high for treatment initiation at lower health level. We have seen in all the countries that we are working now that there is an increased access to bacteriological confirmation, including the resistance pattern. We should not forget about that, because the expert also provides you with the risk resistance. Clinicians and caregivers are generally happy with this non-invasive test, and we get that always reported back when we go into countries. We see that clinicians are very happy that they finally have a non-invasive test that they can readily use at the lower healthcare level. Stool-based testing works also for adults. This is something that we also need to keep in mind. And there are two very interesting articles from Vietnam and China that shows very clearly how successful stool can be used for adults. But we also, as Sabine also mentioned, it should not be used as a standalone test tool. It should be part of a comprehensive package, and that's really important to recognize. Just to say that stool currently was only recommended for expert, as we said at the beginning, testing only. But of course, rapidly TrueNut is also introduced into countries. And there's also need for a rapid drug resistance test, which is the expert XDR, for example, or target new generation sequencing. And many research groups are already working on that to see how it works. And we have been having the opportunity to check how stool-based testing could be done on TrueNut and expert XDR. The manuscripts are in preparations, and these were studies that were done with the SNRL Uganda and ICDR in Nigeria under USAID funding. And we did the development of the protocol in Uganda with the SNRL, where we looked into experiments of its stool-spiked samples. And we also validated the protocol on routine stool samples from people that were confirmed TB patients. And then we handed over the protocol to Nigeria, where they very excellent in 1 month time were able to test 500 children with this new protocol, and the results are really fantastic, because we could very much conclude that stool testing on TrueNut, MTB Plus, and expert MTB XDR works well using a similar one-step stool method. Although it is adapted to the test composition, of course. Also to let you know that there is a lot of resources available to the country, so there are standardized training packages available, and we also have orientation for clinicians. Of course, in the meantime, a lot of materials have been developed, and we are trying to gather this all together. And there is an SOS toolbox from KNCV that you can go to and find also videos on the SOS tool methods, how to do the processing. Those are available in multiple countries, and also in French and in Portuguese. There's a master training that we did for the African side, where we have trained master trainers from the SNL Uganda and Benin and other senior consultants, so they can also go out to the countries and help them with the training. And I'm not sure if you already are aware, but there's a community of practice which is active on stool-based testing to discuss the childhood TB diagnosis, also in the area of stool-based testing and other topics. So that's happening every month. And if you would like to be part of that, you could let us know, and we can add you to the list. And that is organized by USAID in collaboration with KNCV. So some take-home messages to finish with. So guidance from WHO and GLI on childhood TB and stool-based testing are available. Researches on training, SOPs, and data capture forms and tools are available. Stool testing is feasible, as I say, at all experts and TrueNut sites to be said. But although TrueNut's not recommended yet, but we have shown it is possible. Lab staff finds it very easy, and stool is generally well accepted by clinical staff. More children are recorded in the lab registers, and I think the countries will show this also in their presentation. And to be detected is now easier, that the access is easier. Stool also benefits adults, so we highlighted these 3 last ones because these are the things that we really would like to see how we can get more data on, but also to for evidence for recommendation by WHO. So that's stool also benefits the adults. Awareness should be raising with clinicians of value of stool as sample is important. I think there's a lot of work that can still be done. Also on community awareness, it's a lot of things that can be still done there. And the method for an on-the-spot stool collection might further increase the access. So stool swaps is something that we also need to take a closer look into. And I like to acknowledge many people. This is like a slide that I'm bringing together every time when people are, helping with some of the parts of the puzzle. This is a group of people that helped in all the years that we have been working on stool-based testing to make it as far as we are now. And I think the people that are presenting today should also be part of this slide already. Thanks a lot, and I hand it over back to Sri.
Excellent, Petra. Thank you so much for these insights. Without any further delay, I would move to the next presenter. I welcome Dr. Nkiru Nwokoye from Nigeria. She's a medical microbiologist with over 15 years of experience in laboratory services, research, and public health program management. She seeks to bring quality laboratory services to improve health as well as diseases of public health importance. I welcome Dr. Nkiru to make a presentation and tell us about the experiences from Nigeria. Over to you, Doctor.
Thank you very much. So I'll be presenting on scale-up of stool testing, current status and experiences in Nigeria. Thank you for that introduction. So this morning I'll be taking us through Nigerian experience in implementing and scaling up stool-based expert testing. Glad to say that Nigeria has not only introduced or implemented stool-based expert testing, but we have scaled it up. And we will be talking about steps we took in scaling up. So the first thing we did in 2020 when KNCV came on board with the LON project is USAID funded, was to engage stakeholders for a meeting to actually elucidate challenges affecting the low bacteriological diagnosis of TB in children, and also to offer improvement solutions. We found out that the key issue there is that we have a procedure that is not decentralized. The procedure was confined in national reference laboratories because of the safety issues surrounding the procedures. So we looked inwards globally to see what was happening, and SOS method was a very good one for us to decentralize to peripheral labs. So we adopted the SOS method. After the adoption, we developed documents, we developed guidelines, SOPs, and other documents that will help in implementation. Then we capacitated the healthcare workers and we sensitized them on this test. We did that by the use of webinars. We also trained them. We developed a YouTube video that will help those healthcare workers, especially the lab staff, that we are not present in physical training, to actually learn more on the procedures. One key thing we did with the NTP was to introduce what we call the Childhood TB Testing Week. This actually is a game changer for us because it drives demand for stool-based expert testing. In the course of the presentation, I'm going to also tell us more on the introduction of the Childhood TB Testing Week. But this slide tells us about the national guideline on the use of stool for TB diagnosis in children. As you can clearly see, Nigeria has introduced stool as one of the specimens. Is well seated in algorithm for TB diagnosis in children. The one highlighted in yellow is one of the specimens we collect when diagnosing TB in children. Again, it's very critical that we should also look inwards for funding, because funding is needed for implementation, is needed for scale-up, is needed for sustainability. So we considered funding when we started the implementation in 2020. And just like I mentioned, KNCV started this in 2020 when we got the LON project. So then it was USAID funded. However, in 2022, our national program actually took over and scaled up to every state in Nigeria, including the Federal Capital Territory. And stool testing was mainstreamed into the routine laboratory testing by the national program. Today, I'm glad to say that national program provides all the consumables we need for stool testing, and we are sure not to have interrupted service when it comes to stool testing. And this is also very good for us now that TB loan is coming to an end this year. So we are sure of sustainability of this test procedure. So for community engagement and involvement of private sectors, we actually know that it's very critical for us to drive demand for this test because it's coming on board. And we also need to involve critical mass of private sectors because this is where patients go first to seek help. So what we did was, in collaboration with NTP, they introduced what we called, as I mentioned earlier, the National Childhood TB Testing Week. This is a week-long activity that is dedicated to intentionally finding TB cases among children in formal and informal settings, be it the orphanage homes, the malnutrition clinic, immunization clinics, schools, anywhere you can find children. All right. We carry out community sensitization using radio jingles, SBCC materials, and it actually drives demand for this test. And we do that not just in public laboratories, we test in both public and private laboratories. For instance, KNCV, in that phase 1 implementation, had a total of 221 both private and public laboratories conducting expert-based testing, 173 public and 48 private laboratories. So how was training organized? Just to also mention that training was conducted at the national, sub-national, and facility levels, and it was done in collaboration with NTP. The national level training, we started with a webinar for different categories of health professionals, the pediatricians, the DOT officers, lab personnel, clinicians, both from public and private facilities. Even the local government TB supervisors, everybody was carried along. And at the sub-national levels, we have the state TB program in collaboration with partners working in those states, cascading down trainings to the state programs, to the state players, and the healthcare workers in the states. And at the facility levels, we also train the laboratory staffs. We have hands-on practicals on the procedures. And just to also mention that this is not just a one-off training. We have retrainings to ensure that the procedures, the healthcare workers are familiarized with the procedures. Sorry, I have to manually move these slides. This slide shows the data snapshot from stool tests from October 2023 to September 2024 in KNCV supported state, that is our phase 1 implementing states. We can see that over 3 million children were screened in the period under review. About 37,000 were presumed to have TB, that is presumptive TB. And 99% of those presumed to have TB were evaluated. Just of interest to also mention that a chunk of that, about more than 21,000, were from children 0 to 4 years old. 15,000 from children 5 to 34 years old. And this is not surprising anyway, because the earlier presentations has shown us that we have difficulties in collecting sputum from younger children. Okay, so out of the ones evaluated, over 2,000 of them were found to have TB. Again, a good number of them from children between 0 to 4 years old, and about 930 from children between 5 to 14 years of age. About 8,960 of those diagnosed of TB were put on treatments. Okay, so this is the stool test contribution to TB cases, from in children between 0 to 14 years, from Q1 2021 to Q3 2024. In our early days of implementation, we can see that the stool-based expert testing, the contribution wasn't that high. We had between 6 to 8% contribution coming from stool. The blue bars, before I continue, the blue bars represent the total MTB detected both from sputum, stool, and clinical diagnosis, while the orange bars are the MTB detected from stool, and the trend line shows us the contribution from stool. So this stool-based expert testing actually peaked from Q1 2021 when we have intensified efforts in our sensitization, our childhood TB testing weeks, and trainings. So we recorded 30% contribution, and that kind of stayed it until dates. Today we are recording around 20%. But from Q1 2024 to Q3 2024, recorded between 16 to 19% contribution from stool. Okay, so I really need to thank our funder, the USAID, that funding the TB Loan 1 and 2 project currently. I want to also thank the National TB and Leprosy Control Program of Nigeria that has been on the driver's seat, driving the project. The KNCV TB Plus for their technical assistance. I want to thank the participants, parents, caregivers of those children, and the facility staff. I really want to stop here. It is thank you from KNCV family.
Thank you so much. Thank you so much, Dr. Nkiru, for highlighting how Nigeria has successfully scaled up the stool-based TB testing, which decentralized the diagnostic to the lower level labs. Excellent example for replication in other settings. Thank you so much. Next, we move to the next presenter from Bangladesh, Dr. Mazidur, Associate Scientist at icddr Bangladesh. He is working with Dr. Saira Banu's team, and he has been optimizing stool processing methods for expert testing, and he has facilitated widespread application across Bangladesh for detecting TB in children. We also have Dr. Sander Tanzin Hossain, who is a public health professional with 13 years of diagnostic experience in tuberculosis and communicable disease area. He is involved in strengthening diagnostic network systems and building capacity in Bangladesh and Afghanistan. Over to you, Team Bangladesh.
Yeah, thank you very much for the nice introduction. I would first like to thank the organizer for this timely webinar where I will be presenting our team's stool testing efforts. Following my presentation, Sander Tanzin Hossain from FHI will also share his experience testing stool samples through SOS method across the country. So this slide shows the journey of stool expert testing in Bangladesh. In 2017, we optimized the stool processing method at icddr by concentrating specimens through centrifugation. Using stool samples from adults with pulmonary TB, we achieved excellent sensitivity and specificity, the results of which were published in PLOS ONE. In 2018, with USAID funding, we piloted the expert ultra method for children in 4 tertiary hospitals of Dhaka. The results were published in Clinical Infectious Diseases, which showed expert ultra outperforming compared to induced sputum and gastric aspirate. In 2021, with TB-Rich Wave 7 funding, we scaled up stool testing for children to 15 tertiary hospitals in Dhaka. These studies helped to incorporate stool testing into Bangladesh national guidelines for child TB management. The USAID Alliance for Combating TB in Bangladesh, or ACTB project, began stool testing in 2021. Then it expanded to 41 healthcare facilities by 2022. Finally, in 2023, the National Strategic Plan formally adopted stool testing for children. And by 2024, ultra stool testing had been scaled up in 80 facilities by ACTB. Since 2021, we have been conducting facility-based active case finding for childhood TB in 350 healthcare facilities across 50 districts. These facilities include primary, secondary, and tertiary level hospitals. However, stool testing is currently being carried out in 80 of these ACF sites, focusing on secondary and tertiary hospitals. To implement stool testing with expert ultra, we conduct orientation programs for physicians of our intervention facilities to educate them on the testing process, expected results, and treatment. We also train field staff on proper stool sample collection and transportation. Let's now take a look at the performance of stool testing across SATB working sites using data from July 2021 to December 2024. We tested a total of 33,000 stool samples with more than 300 samples positive, giving an overall positivity rate of 4.1%. Notably, around 80% of these positive samples were in the trace detected category. When we break down the positivity rates by age group, we observe a slightly higher rate of positivity in the 5 to 14 years group at 4.3% compared to 3.8% in the under 5 years group. Additionally, about 2% of samples yielded errors and 1% were invalid after initial testing. However, after repeat testing, all of these samples produced valid results. This slide shows the bacteriologically positive cases among children under 5 years with pulmonary TB. As you can see, before implementing the stool-based diagnostic approach, the positivity ranged from approximately 7 to 12%. However, since the nationwide implementation of stool-based diagnostics in 2021, the bacteriological positivity rate among children under 5 has increased by 2 to 3 times, marking a significant achievement. To raise awareness about childhood TB diagnosis, we engage in various outreach activities, including interactive campaigns with puppet shows and folk performances, miking campaigns on branded rickshaw vans, and the launch of the first ever health Olympiad for school children focused on TB. We also hold courtyard meetings and one-to-one discussion with community members and distributing TB-related information materials. Additionally, we have developed a policy brief to educate physicians on stool testing for childhood TB diagnosis to help them understand this alternative approach for rapid detection of childhood TB. Now I will request Sander Tanzin Hossain to share his experience on stool testing using SOS method across the country.
Thank you, Dr. Majid. And thank you so much for inviting me for the presentation. So as Dr. Majid was presenting, I will be actually sharing the Bangladesh experience, particularly the experience of National TB Control Program, introducing and scaling up of simple one-step stool sample testing method. Yeah, so as you know, Bangladesh has a lower TB, child TB case detection like many other countries. And also NTP is in dire need of introducing something new and which is doable at the routine operational level. With that spirit, the former IDDS project back in 2022, they actually supported NTP to train on the simple one-step tool processing method using the gene expert for childhood TB case detection. Later, this stool sample in Bangladesh shows promise for improving the diagnosis of pulmonary TB in children, particularly who cannot produce the specimen. The IDDS project was phased out in October 2023. However, NTP own, sustain, and keep scaling up of this method, this the SOS method. And NTP started capturing the data in the programmatic level in July 2023. And also with that aspect, NTB revised the monthly reporting format from the that comes from the gene expert site across the country. As of September 2024, 198 gene expert site perform stool testing. What actually key insight we have learned through this intervention? Gradual expansion of number of sites performing stool gene expert test from 112 to 198. And if I say that IDDS actually supported NTB to train the staff of reference laboratory in the 5 regional area, and later NTP actually scale up this up to 198 gene expert site. This is a great example of country ownership. And total test per quarter increased from 1,200 to around 6,000, indicating a growth in testing capacity and testing uptake. So this expansion, this growth is going on with these existing synergies without investing any additional resources or any project support with the routine operational setting. Total rifampicin resistant cases detected in Q2 is the highest, it's a 3 patient. If there is no SOS system in place, otherwise we would have missed those cases or we diagnosed in delay. MTB positivity rate peaked in Q3 2024. That was around 3.57%. And most importantly, you see there are several methods of stool testing, as Petra was mentioning, and there were several global evidence. And it is very encouraging that at the national level by the government of Bangladesh, National TB Control Program, they implemented this SOS method, and it has been widely accepted at the field level. And it has been technically feasible, and NTPs keep scaling it up. So now I would like to request Dr. Mazidur for the next slide. Yeah, the conclusion and the way forward. Thank you very much.
Yeah, thank you, Tanzin bhai. Very nice presentation. So to summarize, I would like to say that the successful introduction and scale up of stool testing have significantly increased the detection of bacteriologically positive TB in children under 5 years of age. This is a crucial advancement in identifying and treating TB in this vulnerable age group. Additionally, healthcare providers have shown strong acceptance of this approach, which is essential for the sustainable success of such initiatives. The large-scale sensitization and awareness campaigns around childhood TB diagnosis have played a key role in increasing detection rates. While the SOS approach has been valuable, it is also important to note that some trace-detected cases may still be missed. This emphasizes the importance of using the centrifugation method where applicable for better detection of child TB. Moving forward, we must ensure proper logistic support as well as continuous training for both laboratory and field staff. This is crucial to maintain the quality of efficiency of the testing and treatment process. Lastly, developing standard operating procedures for screening, specimen collection, and referral will be key in standardizing the process and ensuring that all necessary steps are consistently followed. While we have made significant progress, these steps will help address any remaining challenges and ensure the continued success of childhood TB diagnosis and treatment in TB control program. Thank you very much. Thank you all.
Thank you, Dr. Mazidur. Thank you, Dr. Tanzin. Very nice presentation, and thanks for highlighting how you scaled up the SOS method. And not only that, how you demonstrated the effectiveness in improving the pediatric TB diagnosis, its integration into the national guidelines, and also emphasizing the critical role of awareness campaigns. Thank you. Now I move to the next presentation from Vietnam. I welcome Dr. Hien Mai, who is a medical doctor and a public health professional with 15 years of experience in designing, implementation, and monitoring of TB projects. She's been providing TB technical leadership and implementation in collaboration with National TB Program, funders, and other key TB stakeholders. I welcome Dr. Hien Mai. Over to you.
Thank you. Hello, everyone. I'm Dr. Hien Mai from USAID Support to NTB project. FHI is in Vietnam, so I'm very happy to be here to present about the stool testing for diagnosed TB in children in selected provinces in Vietnam. Yeah, so first of all, I would like to provide very brief information about the pediatric TB context in Vietnam. So in Vietnam, around 25% of the country population is children less than 15 years old. And according to the WHO report in 2024, they estimate that in Vietnam in 2023, we have 7,400 pediatric TB cases, account for 4% of the total incident. However, the national TB program in Vietnam, they only notify 1,168 pediatric TB cases in 2023, account for 1% of the total notification. So it means that in our country, 84% of the pediatric TB cases were not diagnosed or diagnosed but not notified in the TB system. So that's why it's called urgent need to accelerate the pediatric TB case finding in our country. For stool testing implementation in Vietnam, the NTP pilot stool testing in 2020 in 10 health facilities at 5 provinces among children less than 15 years old and people living with HIV more than 15 years. And then the NTP scaled up to nationwide after that. For our project, the USAID Support to NTP project, we start the stool testing in July 2022 in our 11 provinces among total 63 provinces in Vietnam. And we implement in 48 districts of the country. For the project, for stool testing, we focus on the children less than 15 years old. Including the children with TB symptoms, children at risk, including the household contact, previous TB treatment, malnutrition, and immunodeficiency disease. For the stool testing, we use the Gene Expert and Gene Expert Ultra for test. And given we know that Gene Expert Ultra is more sensitivity rather than Gene Expert, however, it depends on the supply in the country. And for monitoring and implementation, we integrated into the routine monitoring our activity in the facility and the community. So this slide will show you our algorithm for the pediatric TB detection under the project. We are screening TB for the children in both health facility and the community. For health facility, we work with the pediatric hospital and general hospital to screening the TB. And we focus on the children with TB symptoms, children at risk, and children who have available chest X-rays for any reason. We screen by the different model, like we call intensified case finding, active case finding, and hybrid model. I will mention more detailed information in next slide. So during this setting, we process our algorithm for the diagnose through the order the step. The first one, we provide the clinical exam, includes the risk assessment and physical examination. And for the presumptive TB children, we indicate the chest X-ray. And we use chest X-ray to triage for the Gene Expert test. So we call this is double X strategy, include chest X-ray and Gene Expert. For Gene Expert test, we use the different specimen collection, including the sputum, stool, gastric aspirate, bronchial aspirate, and CSF. And stool is one of the specimens that we use for the Gene Expert. For any case, if the expert is negative, we will provide the clinical consultation for non-bacteriological diagnosis. In order to diagnose pediatric TB, we apply in the diversified model under the project. On the left hand, you can see that we call the intensified case finding model that we apply in the health facility. For any patient with a clinical TB symptom or TB risk factor, or patient who indicated for chest X-ray with any reason, we will screening intensively in the health facility by double X strategy. On the right hand, you can see that we have active case finding model in the community, including the campaign. It means that we have a health provider team go down to the field for a short period of time for around 10 or 15 days, and we are screening the TB for the household contact and high-risk population by double X strategy. We also have another model as a committee we call single X. It means that we provide the gene expert test for any risk population with cough and have a sputum more than 2 weeks by gene expert and without chest X-ray. And the last one is a self-screening. We apply the QR code for the general population to find any people who have a high-risk factor, and we refer to the health facility for further diagnosis. And the middle one is a hybrid model. It means that we refer the household contact actively to the facility for the double X screening. This is a result of the student of the pediatric TB detection within the project from July 2022 to November 2024. We screened more than 96,000 chest X-ray, and based on that, we performed 6,300 expert tests, and the expert positive proportion is 1.5%, and we diagnosed 136 TB cases among of them, and 97% initiated TB treatment. Look at more detailed information about the expert test for 6,300. We can see that for the children less than 5, majority of specimen is stool test. It's count for 54%, and we found 4 stool expert positive case and account for 0.2%. For children more than 5 years old, the stool specimen only account for 17%, and we found 10 case with the stool expert positive, and it is account for 1.9% positive. Among 2,300 stool tests, we see that for the gender, stool expert positive and clinical diagnosis among male is higher, significantly more than female. It is similar with the TB patient distribution in the country. For the S, we can also see that given the children less than 5, we have a number of stool tests is 3 times higher rather than children more than 5. However, the positive rate among the children more than 5 is higher rather than less than 5 for both stool expert positive and clinical diagnosis. For the duration of the implementation, actually is no much different between the duration. For the symptom, we can see that almost of the children who have a TB diagnosed with the stool test have a symptom. However, we also found that around 40% of clinical diagnosed have no symptom. So it means that if we rely only on the symptom, we may miss some TB case. So during the implementation for stool testing, we can observe a lot of challenges, and we also have a lesson learned for our project in particular and for country in general. First of all, we see that the potential loss to follow-up of risk as the children, they cannot collect the specimen at the campaign or at the facility. So that's why they need to back their home and collect the specimen. So we observe that a lot of some cases were lost to follow-up. when they come back their home. So in that case, we to address this issue, we update our SOP and include a very clear stool specimen collection and stool specimen indication clearly in our SOP. And we also try to engage health collaborators to support the follow-up those children who back their home for the specimen collection. In Vietnam, we also observe that the export and export ultra-gastric shortage for a long time, especially in 2023. And based on this lesson learned, the country have a plan to improve the supply chain, and in 2024 is much more better rather than in 2023. And we have enough export ultra for the testing right now. The second challenge is related to the healthcare system. We observe that it is inefficiency linkage between the pediatric and TB care system. It is because in Vietnam, the pediatric and TB care system is a two vertical system. And normally, when the children have a sick, the parent will bring the children come to the pediatric hospital or general hospital rather than the TB hospital. So the stool specimen will be collected in the pediatric hospital. However, the export test will be implemented in the TB system. So because with the inefficiency linkage between two systems lead to the limited stool testing implementation. So to address this challenge, we work with both two systems and create the mechanism or linkage between two systems in via the TA mechanism, via the capacity and training for both the pediatric TB and the TB doctor as well, regarding about the pediatric TB diagnosis and the stool testing. The last one related to the client perspective. In Vietnam, the general population, they are lack of awareness about the TB in children and the stool testing as well. And normally, they, as I mentioned above, normally they bring their children come to the general and pediatric hospital instead of the TB hospital. So for the project, we are planning to develop the community communication campaign to raise awareness about the TB in children. And to maximize the outreach of the high-risk population on the pediatric TB, we also integrate the pediatric TB detection into the existing system in the pediatric hospital and in the general hospital. And besides that, we also apply the diversified model to maximize the outreach, as we mentioned above, including the intensified case finding model or active case finding model, as I mentioned above. So we would like to acknowledge USAID Vietnam National TB Program and our priority province for their great contribution on the project implementation and project result. And thank you all for the listening.
Thank you, Dr. Hien, for a very nice presentation and bringing the insights from Vietnam. Very much appreciated. Now I open the floor for the question and answer session. I suggest the people who have questions could raise their hands. And while you ask the question, please be specific. This question is addressed to which speaker. The floor is open now for the question and answer session. I have 2-3 questions myself, and we have audience from different sectors. So we have Dr. Mario, who have been the former director of Global TB Program. Dr. Mario, what
Hi.
are your views? Hello, how are you?
You're putting me on the spot. So, no, I was meditating after hearing all of this, very promising, by the way, very promising experiences, right, from Nigeria, Bangladesh, Vietnam, etc. So let me say something also going back to history here, right? So childhood TB is truly the Achilles heel, right, of TB care. It has been. Numbers are striking. Now we are talking about 12% of all cases, I believe, in the latest estimates. So we're talking about 1.3 million children. Roughly about half of them are notified, which means that 50% are not detected. 160, 170,000 children die every year for a disease that is otherwise, can be diagnosed with difficulty, certainly can be treated. The overall consequence of this is what used to be, is not much change. There is progress, but used to be a very slow progress towards the treatment coverage in pediatric TB. So going back to Easter, I was saying, I think when I first encountered the problem, that was in Africa about 30 years ago or so, in countries such as Uganda or Zambia, where TB was strongly associated with HIV, obviously, as it is still today, but there was really a crisis situation. And I remember visiting pediatric hospitals and divisions in those countries and talking to physicians there, who were the most prominent in those countries, who were essentially unable to make a diagnosis of tuberculosis because the technological tools that they had available were just inadequate, right? We realized the importance of TB at WHO, not just at that time, but more prominently, I would say, at the beginning of this century. And that's why then there was at a certain point the creation of an establishment of the working group on pediatric TB that was managed by people like my ex-colleagues, right? Małgosia Ziemska. I see that Annemieke Brands is still there, obviously working on this very issue. And they know it all, right? When we established the first roadmap, and now I saw the presentation, so we are now at the third level of roadmaps for children. So we must recognize that there is progress. In terms of treatment, well, we still have the possibility of using the 4-month regimen with the traditional drugs. We need studies on other type of regimens in children specifically, which is obviously always a neglected area. I'm now involved in clinical trials on new drugs, and I see the difficulties in including children or including even women because of the fear of pregnancy and the side effects. So clinical trials themselves must be pushed. Researchers must be pushed to invest on this type of studies, whether it is treatment or whether it is diagnostic. Now, going to specifically to the stool testing, I believe that this is clearly, I look at the data, so it's clearly promising. We know now that, and it's a recommendation by WHO, that a comprehensive package works and is better than just trying to rely on the old methods of the sputum or the aspirate and so on and so forth. And it's something non-invasive, which is another important issue here. So I think that all of this is quite promising and is reassuring that we are advancing. I think the progress is slow. I don't think the progress is really accelerated, and that's why I think the TB community needs to work both with the researchers on one side to push them to invest on trials in children, and at the same time with pediatricians when it comes then to the care part. So really the pediatric societies, let me use this term, must be, or communities must be involved, because national programs oftentimes do not reach out to pediatricians, and they are not necessarily connected. So we must implement an advocacy campaign, if I can use this term, and I'm looking at Vineet particularly here, in Southeast Asia, and a strong advocacy campaign in Southeast Asia and globally, obviously, but I'm particularly interested in Southeast Asia here today, to engage as much as possible pediatricians and teach them that there is nowadays a way to do better things than it used to be. So with that, I know after this, just to conclude, I'm reassured that there is progress, and thanks also to KNCV and to all the donors that have been putting their efforts into this. And WHO, as usual, right, looks into all of that, and when it is the case, comes out with recommendations that in this case are quite strong because they are evidence-backed. Thank you.
Thank you, Dr. Mario. Thank you. I see a hand raised. I don't see the name. It is NTI WHO-CC. Could you please ask your question? Then followed by Blessy.
Good evening. Thank you for excellent presentation. I have question regarding whether there is any experience with usage of rectal swab.
Would
Can I
like
answer
to,
this, Sri?
yeah, please.
So to my knowledge, there has not been much evidence yet collected on rectal swab. The only data that we have is from doctors or pediatricians are telling me that if the child is very sick, they sometimes take like a rectal swab, or they take a pink, as they call it. So they take a little bit from the rectum to test, and that has been very successful. From what we know from the SOS Stool method, that we can go as low as 100 milligram. 100 milligram is like what you can pick up with the rectal swab. But so far, we have not been able to get any study on the conduction of rectal swabs. So this is really something that needs to be studied.
Okay.
Thanks a lot for this good question.
Okay, thank you.
Thank you.
Second question is, what was the comparative method used for this study? Whether culture was used as the gold standard reference?
So culture on stool is very difficult. As you know, there's a lot of contamination that will occur, and that's why it's not that much recommended. But we have done the publication that you will find on accuracy, have done the comparison against culture, but also against expert sputum. And the sputum, of course, could be induced sputum or gastric aspirates or any other kind of sputum. So that's something that, and we can easily share those publications with you after and we can bring that to your attention. Yeah. And it is a nice study also done in China, where it was done on adults, and there was a varied of other tools used, also midget, LJ. There was a lot of different kind of methods used to compare it, and then the stool came out very excellent on expert.
Okay, thank you very much.
You're welcome.
I would just go to Dr. Mohammed Yasin.
I think
from the fundus, from the fundus perspective, Dr. Mohammed, what you said, there's a recurring theme in several presentations is the urgent need for improved access to consumables and cartridges. What role can you play or Global Fund play in ensuring that funding during the grant making process is inclusive? Over to you, Mohammed.
Thank you very much, Shri, and thanks WHO and all the colleagues. Very interesting presentation, promising result. I'm also happy that almost all the 3 countries presented, they started a small scale piloting and demonstrated good result, and this were scaled up, including through the Global Fund grant. And that's very important. So it's demonstrating evidence, innovations with the WHO recommendation. This are scaled up using Global Fund and other domestic funding. And for Global Fund countries supported by the grant, we see TB diagnosis among children is the most challenging one and difficult to achieve even the target. But understandably difficult to diagnose TB. And with this stool, non-invasive option available for countries, especially countries which have less capacity to collect other extrapulmonary samples, including nasogastric aspirate and lavage and so on, which are expensive and requires expertise. The stool examination is actually a game changer, and good to see the performance of the test and expanding this to use gene experts and then now through NAT. This is the way forward, and we all are looking for more point-of-care diagnostic tests. But in the meantime, we need to expand the available ones. And I see that the 3 countries presented today, the proportion of children among notified cases are 1% in Vietnam, 4% in Bangladesh, and 10% in Nigeria. And you can see that it's a long way to go. But these are good lessons learned, and from Global Fund side, this is well aligned with our investment, targeting high-risk group, children a high-risk group for TB. Any investment, any savings should be prioritized to scale up those innovative and less invasive and accessible technologies. And the cartridges are available, and this should be prioritized for children. And I don't think there is other high-risk group which should be prioritized than children, where we are missing many children in many countries. So this is in line with Global Fund investment. I just want to encourage countries who are accessing Global Fund grants to explore options for reprogramming of the current grant while thinking about the next cycle GC8, where this would be one of the priority areas. But in the meantime, they can use existing savings reprogramming, and Global Fund is fully supportive of this approach. Thank you very much.
Then we have Ade Labanson. Could you please pose your question?
So thank you very much, presenters. One of the things that I feel is a challenge in Nigeria is the issue of the logistics for stool movement. Because to move from one point to another, because we've been told that within few hours, maybe 2-3 hours of collection of samples, we need to get them to the point where they will be worked on at the laboratory. Now, somebody earlier talked about the rectal swab. I don't know how I want to actually request that those who are doing research should look into this rectal swab, because it will help a great deal. And more importantly, also, the children, when they come to the facility, they may not want to pass stool at that point in time. So if you do a rectal swab, the possibility of getting the specimen right there and then, as you are seeing the patient, is very, very high. And then that will also help us to increase the diagnosis of TB in these children. And I think we should look into that. Number two, the second person that presented from Netherlands talk about adults also producing stool. I would have loved if this could also be looked into, so that WHO will give us the guidance on how to do this. Because at times when you see them at the facility, some of them will say they cannot produce sputum. In fact, at least even in the community, when we do community outreaches, some of them will say they cannot produce sputum. So we can encourage this cohort of adults to produce too. But because it is not within that algorithm for us, except if it's something new, something new in the guidance, then, which I don't know, then I would want to suggest that those who are doing research should also look into this. How good is it for us to collect stool from the adults, particularly also in the community, so that we can also use this opportunity to increase TB case finding among the adults. Thank you.
Thank you. Well noted.
Can I make a quick note on this, Sri?
Please.
So just to also make clear that there is already quite some data on using the stool on the adults. I already showed the two publications that are available, but also many countries already have adults in their guidelines, so they already added it. Like I know from Zambia, for example, they are including also very ill hospitalized patients, and there are countries that are also including, like in Vietnam, they are also including the people living with HIV, and there's a lot of success among that, and they see that it is really helpful indeed, as you are stipulating. And for the rectal swab, I just want to make clear, we have now official evidence that we can go as low as 100 milligrams, as I say. So we didn't know that low amount of stool would be successful, as we were always looking for a larger volume of stool. So knowing that is available, that's possible, I think we should really move very quickly into having some studies done on rectal swabs. So thanks a lot for that. And it would be nice if we could do this in Nigeria also.
Thank you, Petra. Then we have hand raised Hien Mai. Could you please pose your question?
Yes. Thank you. And thanks for the presenters and with the good presentations. I noticed that the methodology of the stool J expert is all and then using the SOS method. And in Myanmar also, we also have pilot study with use of the SOS method, and found that among the 2.6 21 per 817 samples, that is 2.6%. We found that 2.66% positivity. What I worried is about the methodology, because of we are planning to implement the whole country soon. That's why for the implementation of the whole country, we have to use, according to the WHO recommended SOS methods or other modified methods such as centrifugation, more centrifugations, or use of the true samples in required conditions. Please answer for these complexities. Thank you.
Any speakers would like to take this question, maybe from Nigeria, Vietnam, or Dr. Mazidur?
Okay, so I will take this. This is Nkiru from Nigeria. Okay, so you are doing well. 2.6 is good to start from somewhere. So, but again, there are early beginnings. When we started, I just give you a Nigeria experience. So when we started, it was not so rosy, all right, because we are just starting new. So when 2.6 is low, however, there are so many factors that may be responsible for that. We started with a webinar to sensitize and train clinicians, pediatricians on the symptoms and signs of childhood TB. That helped us in identifying true presumptives. So one key factor that may be responsible for that is identification of true presumptives. The stool-based expert testing is not for screening, it's for diagnosis. And if you use it to screen a lot of persons to get presumptives, a large chunk of presumptives that are not most likely to be true, you are going to dilute out your yield. That's one. Secondly, the procedure itself. The laboratory persons handling those samples, you need to actually see that they're well trained so that they're giving you the good result that is needed. There are so many factors to be considered, but it's one step at a time. Even today in Nigeria, we still do not have it all 100%, but with continuous evaluations, continuous tracking and monitoring of this procedure and the outcome, the yield, we do that weekly, on a weekly basis. You are able to find out where we have challenges and fix it real time. So I want to encourage you, and just to say that you look into a lot of factors that may have contributed. Thank you, and over from me.
Any insights from Vietnam and Bangladesh? You would like to share?
Yeah, I'm Mazidur from Bangladesh. So I also want to echo with Nigerian experience. Yes, identifying the true presumptive is really important. On the other hand, you think if in the root levels where there is no any centrifugation facilities but has the expert system, you can use the SOS method. However, if any tertiary levels or the well-equipped laboratory where there is excess of stool samples, I think they can also utilize the centrifugation method also, because the yield may also be increased. So the use of different methods, it also depends on the perspectives of the laboratory capacity also. So I think in that case, we should also consider in different situation also. And he also asked whether the two samples would yield the positivity rate. I think, yes, maybe there is a possibility, but, I think even if you test one trace detected cases with one sample, another sample, even with the same sample, if you test again, there is a possibility of getting the negative results, because the TB bacilli that is not uniformly distributed within the stool samples. So increase the number of the samples, it will again increase the cost. So yeah, thank you.
Thank you, Dr. Mazidur. We could not speak to Blessy Kumar. Blessy, are you there? If not, then can we move to Dr. Manpreet Bhalla?
Yeah, thank you. Am I audible?
Yeah, you're audible, doctor. Yeah.
Yeah, so thank you. I would like to thank everyone for their very good, excellent presentations. We heard from Nigeria, Bangladesh, Vietnam. I'm from India. I'm Dr. Manpreet Bhalla. I'm a microbiologist and I'm the director at NIDRD, National Institute for TB and Respiratory Diseases. So I would just like to share our experience also. We also did a study in pediatric patients from stool samples. We were able to do it only for around 200 as a pilot study, 200 children, because we had some shortage of, we only had limited cartridges, because we used Expert Ultra also. We used the normal G4 cartridge, and the comparison was done with the sputum and gastric aspirate, as well as and culture also was done. So we used all tests for comparison, and the results actually are not yet, we have not analyzed the results, but from the finding we found that we got very good results. They were comparable, the results of stool were comparable to that of GA, gastric aspirate, and sputum also. So we would like to also go ahead and do some bigger studies. And since ours was a tertiary care hospital also, our selection was like it was we used the already the highly suspicious children were included. So that I would just like to wanted to share my experience. Thank you.
Thank you, Dr. Bhalla. Dr. Sabine, are you Vineet? Vineet, do you have any question?
No, I don't have a question, but I think it would be important if you could just take 2 minutes of a community representative's perspective.
Yeah.
Blessy, I'm not sure if she's still around, but I also saw Paran, who's a community representative in this meeting. So if any of the community representatives here would like to take the floor for a short intervention on community support and what they think about the stool testing.
Absolutely. Yeah. I do not see.
Leslie just posted something, I see. So that's good.
Sure. Yeah. Yes, Sharan Gopali.
Hi, thank you. Thank you for the opportunity, and it's very, very comprehensive presentation from the 3 countries, and it's very encouraging for us to work in the community, especially, yes, collecting the sample from the community is always a challenge, especially when we focus the children. So doing this stool examination will definitely motivate the mothers who carry the children. And the role of the community will be also clearly defined, that we are working closely with the female community volunteers, mothers groups in the community. I think this will be one of the two where we can advocate, where we can aware the mothers in the community about the importance of taking their children for the stool test. Instead, if they cannot go for the gastric level, sometimes it's a painful and they have to go to the hospitals, which is far from the community. Introducing this approach will definitely support finding the childhood TB, early childhood TB, country like mine from Nepal. Thank you very much.
Thank you, Sharan, for giving us this perspective. Any reflections from the speakers? If not, then I would have a question for Siva, who is a laboratory expert having plenty of experience in this field. Siva, are you around?
I think he has left.
He has left, is it? Okay. If Sabine is around?
I'm around.
Okay. Sabine, there is a question on the recommendation on concurrent testing of 2 samples. So this poses a significant challenges in many high burden settings where obtaining sputum samples can be difficult. So what is your recommendation? How this new recommendation can be operationalized or integrated into the national TB diagnostic algorithm for children?
Yeah, thanks very much. I was trying to address that in my presentation. I think, you know, the evidence shows that sensitivity is increased when you use multiple specimens. So I think if it's possible, it should be done, right? To increase that yield, to increase confirming TB in children. So, but of course, we also realize that especially the respiratory sample part of this recommendation remains a challenge. And as I indicated in the presentation, it will really depend on the situation in the country, the level at which things are implemented and what can be done. So for taking respiratory samples, especially in young children, obviously you would need to do a gastric aspirate, you would need to do a nasopharyngeal aspirate, and you need skills for that. You need consumables, you need equipment. So those are potential barriers in making that work. And I think it will really depend on also seeing it in the bigger picture of health system strengthening and decentralizing services to the lower levels of the healthcare system. So one needs to look at capacity building, ongoing mentoring, also making the whole PSM part of things, the procurement and supplies. So and then really looking at the systems that need to be in place for that. That said, if it's not feasible to implement, especially at the lower levels, it will be important to try at least to get 1 specimen. And of course, there your stool testing really is critical because it's non-invasive. And of course, there are challenges in getting it on the spot, as has been indicated as well. But it remains a very good alternative, and in fact, it should in many settings be the preferred sample to take, right? So I think it really depends on the situation. If it's possible to take at least 1 specimen, that needs to be done. Now, of course, in terms of the accuracy, we see that stool is sort of almost comparable to respiratory samples in terms of how well you can pick up the bacilli there. Of course, you can also see the different operational issues in terms of differences in yield, for example. And I think if it cannot be done, and of course it will still come back negative in many children, right? As you can see, the yield is relatively low, also depending on what your definition of presumptive TB is. But in programmatic settings, you will not expect more than 20-25% of children to actually have bacteriological confirmation. So what remains important in the absence of highly sensitive tests that we can use on children and on different specimens in a child-friendly way, the clinical diagnosis will remain very, very important. And so even if you can do stool testing, if it comes back negative and there is a high likelihood of these children to have TB, the healthcare workers need to be capacitated to make a decision to start treatment. And as I put in the chat, it's also important to do that at the lower levels of the healthcare system, because what happens is if you miss a child with TB and they truly have TB, you cannot find the bug, you will just treat them for pneumonia, but they actually have TB. So ultimately, these kids will progress to severe forms of the disease, and they will end up moribund with TB meningitis at the tertiary hospitals. And we've heard a lot of experiences from specialist pediatricians working at those levels, which really shows the need to improve case detection, diagnosis at the lower levels. So until we have much better tests, we will need to look at an integrated approach, including clinical judgment. Chest X-ray, of course, is also very important. And there's also a lot of data being generated and work ongoing to validate CAD, computer-aided detection, on chest X-rays for children specifically, because currently we only recommend it for screening for the age group above 15. So that work is also ongoing. That will also help as one part of the puzzle and the approach to finding more children with TB. So I hope that clarifies. Thank you.
Thank you, Sabine, for this comprehensive response. Then I will move to, we really want to hear from the community representatives how they can support the program. Blessy, are you around?
If I'm so, around, but for some reason, you're not able to hear me. Can you hear me now?
Yeah,
yes, Blessy.
We can hear you very well. So we wanted to just ask, what role can communities play in improving the access to diagnosis of TB among children, and how community organization could support programs in achieving these goals?
Yeah, thank you for that question, Vijayashree, and thank you for the great presentation. It is very, very exciting that finally we have something as simple as a stool test, considering the options we had so far, which were so complicated. But I think we need to, not just say how can communities support the program, but it's a two-way. How can communities be supported and how can communities in turn support? So the first thing is, what the Vietnam colleague raised about awareness. I think it's extremely important that the communities understand what it is. And many times we tend to work in very vertical silos, like the people who are doing the diagnostics only look at diagnostics. Those who are doing treatment only look at treatment, forgetting that it's the same child, the same person who needs to go through that, complete pathway until the person is back on track. So I think we need to converse with them, with each other. There's no point in diagnosing children if we don't have the drugs to treat them. And this happens over and over and over again. Secondly, continuous shortage of cartridges. We have people who are waiting to get their tests done, adults, for months. So I think you also need to look at what can the programs do to ensure this smooth flow. And coming to the communities, once the communities have the right information, I'm thinking of communities in our region, Southeast Asia, everything is by word of mouth. You tell your neighbors about this wonderful test, you tell your colleagues, you tell your community around you, your residential, whatever, you talk about it. So for that to happen, we really need to ensure that the information is in a language that the communities understand. And I'm not talking about community health workers because they have some training already. But I'm talking about lay people on the ground, mothers, fathers, brothers, sisters. Why don't we have something for school children that they can talk about in schools? Why don't we have something that the teachers in schools can? I mean, this is a game changer. And if we're not going to invest on ensuring that the end user has all the information, this will stay at this level, and we are going to be wondering why there is no uptake of this test. So I think it's a two-way mechanism that we need to look at. It isn't just the community's responsibility to support, but it is also the program's responsibility to ensure that there is a smooth flow. There is, can I, as a mother with an infant, go for testing? Can I be assured that once my child is diagnosed, there will be drugs to treat? Otherwise, what's the point of finding out my child has DRTB? There are no drugs. So I'm just trying to say that we really need to look at it holistically. Yes, diagnosis is the first step, but link it to everything. Uninterrupted supply of consumables, cartridges, uninterrupted supply of drugs. Why aren't we also encouraging more, drug developers to develop child-friendly formulations? We have come a long way. We almost have for most of the drugs, but let's keep that advocacy as going as well. So for me, it's a full circle, so I think we need to look at it when it comes to communities, look at it holistically, not as a piecemeal, because that's not going to work. But once again, I just want to say thank you for this. Vineet, thank you very much for organizing this. It's been a great experience, especially listening from the countries, the passion with which they spoke. I mean, there is general excitement. I don't know, Petra, if you can feel it, or Sabine, you can feel it. I know it's got to do with stool, but yes, we are excited that, it's painless, it's easy. Children don't have to go through that horrible gastric lavage that they had to go through before. So let's work together. I think it will take all of us to put our best foot forward in taking this, and I think it will be a success if we follow the steps properly. Thank you very much, and I do apologize for the initial audio. Thank you.
Thank you, Blessy. Very encouraging. So thanks for all the speakers, audience, for great questions. Now I think it's time to hand over the floor to Vineet. Over to you.
Thanks, Vijayashree. First of all, thanks to you for that excellent moderation. And, this made the whole webinar go very smoothly. And although we are well over time, you have held nearly 100 people captivated for this webinar. So great job. I would like to thank all the speakers, all the facilitators for their excellent presentations. But yeah, I think the last few words from Blessy, they summed it all. To have a holistic viewpoint, a holistic approach towards this whole addressing TB in children, which just does not end at one place. Like, it's not just about diagnosis, it's just not about treatment, not about people working in isolation, and not that different constituencies, they just looking at their own respective roles. So it's all of us together for all the steps that require for children to be free of TB, which now I would say also includes not just treatment, but the prevention part as well. So it's about taking that whole picture, the 360-degree approach in mind. So with that, I think many of the countries and participants in this webinar have expressed interest. And once again, while thanking KNCV for their active participation and arranging all the experts and the speakers, we would also, based on the country interest, WHO and KNCV will work together to explore the possibilities of capacity building and countries can share what they think they need, and we'll see how we can manage that. But please do keep letting us know what are your requirements in relation to the required capacity. And of course, one of the points that Plessy mentioned, we'd also keep working with the communities as well. I saw in the chat that KNCV already has some brochures for community awareness and how they can best be used. We will work out on that. But with those words, thanks everyone. Thanks for all the participants for active engagement and keeping this webinar live till the end. Thank you all.
Thank you.
Thank you.
Thanks very much.
Thanks a lot.
Thank you, everyone.
Bye.
Merci beaucoup.